Okay, well, welcome to this evening's Medicine for Members talk. Changing perceptions, making care everyone's business. We've got an excellent audience tonight and it's wonderful to see you all. Welcome. Earlier this week, Alzheimer's Research UK quoted a figure of over 800,000 people in the UK being affected by dementia. And the cost to the economy may be something like £23 million. Our session tonight is so important in order that we can understand this important issue and to find out what we can all do about it. My name is Richard Stock and I've been a GP for 30 years. And I was elected as a public governor of the Royal Free London Foundation Trust last autumn. So if you voted for me, thank you very much. And our governor's role is to represent the interest of patients, the public and the staff of the trust. And we keep an eye on the directors and the non-executive directors to make sure they run this mighty organisation in a proper fashion and that they're all doing a quality job for us. I personally am a Barnet resident, and my initial motivation for standing for election was to play a role in making sure that the Royal Free Hospital Trust merger with Barnet and Chase Farm Trust was positive for Barnet and Enfield patients. And it's over 6 months since the merger, and I'm very pleased to report things are going extremely well on that front. Since my appointment, I've learnt an awful lot about many things. It's been very, very interesting. And the work being performed by the Trust is very special. And I can sincerely state that I've been truly impressed by everything that I've come across so far. Becky Lambert, tonight's speaker, is a fine example of the highly motivated and top quality people that we have working here. And we're very fortunate to have great people in our organisation. Becky, by profession, is an occupational therapist and is a dementia lead for the Royal Free Foundation Trust. With the support of the clinical dementia lead, she's responsible for developing dementia services within the Trust. Now, dementia is so prevalent in our society and it touches so many of our lives. And being a caregiver is not an easy task. And I know both professionally and personally that caregivers also need a lot of support to perform their arduous efforts over what can be sometimes a long period of time that accompanies a dementia sufferer's illness. So I'd like to stop talking now, but to ask Becky to start talking and give us her presentation. And just to let you know, there'll be ample opportunity afterwards to put questions to Becky.
Thank you very much and good evening. Can everybody hear me okay? Yes. Okay. I'm a slightly animated speaker. I don't really like standing still for too long, so bear with me if I move about. I'm very grateful to be asked to come and talk to you guys today, and thank you very much for indulging me. Hopefully by the end of the session you'll know a little bit more about me, a little bit more about dementia, and a little bit more about how the Royal Free is trying to address some of the issues that we're coming up with. So to start off with, we brandish this word dementia around, but I'm actually going to hand it over to you. What do we mean when we say dementia? Nearly gave you the answer then. What do we mean when we say dementia?
Forgetting.
Forgetting, yeah. Confusion. Brain disease, absolutely. So the word dementia itself is actually an umbrella term. It describes a set of symptoms that may well include things like memory loss, difficulties with thinking, problem solving, planning, sequencing and language, but it describes a set of symptoms that you can experience. And you're absolutely right, it's caused by disease of the brain, such as Alzheimer's disease or a series of strokes. There are in fact 4 that are considered the big 4. So you've got Alzheimer's disease, which has the highest prevalence of dementia diagnoses in the UK. You've then got vascular dementia, Lewy body dementia and frontotemporal dementia. They're the big 4, but there are a number of other conditions here, and I'm sure any of the doctors in the room can go into a bit more detail about that if you want them to at the end. But the point is really that the different types of dementia have different disease processes. They have different treatments. So although we hear this term dementia, there's actually a very unique element to it. I'm going to talk to you a little bit about a bookcase, okay? So I want you to imagine that every one of you has a bookcase next to you, okay? And in these books are all of the facts and figures and details and events that you've ever experienced in your life. And when you have dementia, it gets quite tough to try and pull out the right book. So if you think about Alzheimer's disease, and the primary indicator for Alzheimer's disease is about short-term memory. And if you've had experience of people with dementia, you will often know that you'll have somebody who's maybe kind of 85, 86, who maybe believes that they live at home with their young children, that they still live at home with their partner who may have died previous years. And actually, if you think about the bookcase analogy, that the memories at the top are from when people are in their 80s, 90s, 70s, 60s, 50s, 40s, 30s. So the books that are down here by your knees might be the ones from when you were kind of younger and living with small children. So for somebody with dementia, when dementia comes along and it's progressive, it'll shake that bookcase and the books start falling off the bookcase. So when you go to retrieve your most recent memory, it might not be the ones right at the top that you're able to retrieve. It might be a bit further down. And because we know that dementia is progressive, it'll keep shaking that bookcase and books will keep falling off, and it'll be even more difficult to retrieve the more recent memories, and it's the ones down kind of from years and years ago that are the easier ones to retrieve. And so that's kind of what dementia can be like within a bookcase. We also have a second bookcase attached to all of us. So we've got the one with all the facts and figures and details, and then we've got another one. And the second one is all the emotions that we've ever experienced that were attached for every book in the first bookcase. And dementia can come along and it can shake that bookcase as much as it likes, and none of those books fall off. Because the emotions we experience as human beings never leave us. Even if the details of the event, the details of it might disappear, but the emotions never do. And for me, that's a really, really important part of dementia care. So what we're going to cover today is a little bit about me, why I feel like I have the right to stand up here and talk to you guys, and why I've been asked to come and talk to you guys, but also think about the perceptions of dementia and how we perceive people with dementia, the challenges that are faced at the moment with addressing their care needs, and how the Royal Free is actually taking on that challenge and trying to address some of those issues, and then a little bit about becoming dementia friends. So hopefully that sounds okay to you guys. So I want to start off by introducing you to a couple of people. Here is my grandmother, who is Miriam Fitter, who we used to call Janny. And we called her Janny because my grandmother, when she was little, couldn't say the word gran. So my great-grandmother was Jan. And then when my grandmother became a grandmother, she wanted to be called Janny. And next to her is my grandfather, Janny Dad. So Janny was born in Malta. She was raised in Malta, Scotland, Gibraltar, and very much in a naval environment. She loved reading. She was into her nature conservation and archaeology. She worked as a company secretary. Her Christian faith was very important to her. She was the mother of 4 children, grandmother of 6 grandchildren, and she was incredibly precise in the way that she did things. She had this amazing skill of being able to divide a cake into 18, 15, 12, however many people were in the room would have exactly the same size portions. We noticed in about 2001 that there were some changes we were experiencing with Janny, and she was actually diagnosed with Alzheimer's disease, and she was started on Donzapril initially, which is medication for Alzheimer's disease, and it had very little effect for her. She was cared for by Janny Dad for the entirety of her life. She loved being surrounded by her family. She did experience a couple of hospital admissions because she was a walker. Once she was up and walking, she would walk and you couldn't stop her, and she did have a couple of falls. We noticed quite a significant change in her over 10 years. She began to lose her language, and she needed lots and lots of care, and she needed lots of care from my grandfather, and it would often take an hour to get her to eat any food. So we could see that change in a long period of time for her. She very sadly passed away on the 21st of January in 2012, and she definitely only lived as long as she did because my grandfather cared for her. So Janny Dad, he was always playing games. He was always up to mischief. He was always making us laugh. He was a very religious man, but he was a massive practical joker. He was incredibly caring but very matter of fact, and he loved walking on Dartmoor, and he would often take Janny with him for these walks on Dartmoor, even if she ended up sitting in the car watching him walking for miles and miles. But he cared for Janny 24/7. He only accepted help from us family when he really needed it, if we were there visiting. He involved her in absolutely everything. Maybe sometimes not necessarily things that she might have enjoyed doing in her past, but she was involved in everything and surrounded by us all the time. He was completely dedicated to his wife and to all of her care needs, and he arranged for her brain to be donated to Alzheimer's research, to the brain bank, for research afterwards. We actually found after her death that she didn't have Alzheimer's disease, that she had Pick's disease. So I don't know how much it would have changed our disease process, and if I knew now, if I'd known back then what I know now about dementia, I might have been able to pick that out differently. But one thing that Janny Dad, it always struck me for, is that he really prayed that she would pass away first, because he was concerned about the care that was available for Janny had he passed away first. So grandparents obviously very important to me, and have played a massive part in kind of why I've come on this dementia journey as well. And it was watching Janny change over the years, and it was watching Janny Dad being able to respond to those change that really helped to inspire me into kind of dementia care and into wanting to address some of the issues that come up. So, a little bit about me. I'm a singer. I enjoy running and doing assault course events. I like the comforts of home, but I can't really sit still for very long. I like being needed by my friends and family. I really like the royal family. I'd rather be cold than hot. I hate eating cooked fruit. I'm very much a dog person. I have a dog, and I have a slight tendency not to really trust cat people because I'm such a dog person. I don't like being tested, and in fact I spent most of my teenage years saying if it's not in the exam I don't need to know it. I don't really like being late. I have quite a specific way about hanging up the washing. But you know, there's a few quirks about me, but I'm sure there are many, many more, and eventually you'll understand why I've told you such random details about myself. Okay, and in terms of my professional career, well, my mum was a nurse, and she inspired me to know that I always wanted to work in healthcare. And actually from the age of 17 I started working as a nursing assistant in a hospital in Bristol. I moved to London and I decided I needed to get a practical job, a good solid job. So I actually decided to be an occupational therapist, and I qualified as an occupational therapist in 2006. I moved back to Bristol and I worked there in older people's medicine and also stroke rehab. Decided I missed London, so came back to London, worked at the Royal London Hospital in the medical admissions unit, worked in the London Chest Hospital in respiratory medicine, but eventually came back to where I knew I wanted to be, which was geriatric medicine at Mile End Hospital, and so I worked in geriatric rehab there. I then was very, very lucky, because as much as I knew where I wanted my career path to go, it was about opportunities coming up, and actually that's where I ended up at the Royal Free Hospital. So I came here it must have been 18 months ago now, nearly 2 years ago, in working in a dementia specialist occupational therapy post. It was funded by the Health Foundation, and it was about looking at the discharge process for people who have dementia. It was looking at streamlining and bettering the service that was in place to address some of the challenges that there are, like the length of stay being longer for people with dementia who come into the acute hospital. It was funded by the Health Foundation, and we were able to kind of make some really significant changes. We actually, during the length of that project, reduced the length of stay for people with dementia by 2.6 days, which was the first success. We managed to decrease the reattendances to A&E by 26%, and the most important one for me was about reducing unnecessary placement into a 24-hour setting. So for the 34% of patients who were seen through who were at risk of it, we got 100% of those people supported back home, and there wasn't an increase in readmissions subsequent to that. So it was really, really good. And from that project, I then became the dementia lead here at the Royal Free. So a bit of a dementia journey. One thing that struck me, though, throughout my entire journey so far, is actually the perceptions of people with dementia, and that's always something that's really bothered me, the language that we use and the perceptions that we have. So again, I'm going to throw it to you. When we think of dementia, what words spring to mind? Repetition, absolutely. Confusion. Senility. Inappropriateness, yeah. Frustration. Loss of independence, yeah. So all really positive terms, aren't they? Great, isn't it great? When we have dementia, everybody thinks really positively about it. And that, yeah.
Well, my husband has started dementia, and he won't have the word because he thinks it reminds him of badness.
Absolutely, and that's very, very true.
I deny all the time about I'm not mad.
Yeah, I completely agree with you. And I think that's one of the challenges, because actually at the moment, the words that spring to mind are all pretty negative, aren't they? You know, it's all about disease, it's all about, you know, this thing's wrong, and depression, mental disorders, aggression. When, you know, my grandfather was very much of a can-do attitude, and that actually we should be able to live with and not suffer from. And for me, the perceptions and the language that we use around dementia is really, really important in trying to make that change. I always ask the question whenever I do training, do people with dementia wonder? And I always get a murmur of, yes, yes, they do. And I always say, no, they don't. Why does somebody with dementia wonder? Why are they perceived as wondering? When we have people on the ward who walk around in circles, if they don't have a diagnosis of dementia, they're exercising, they're stretching their legs, they're exploring their environment, they're doing something that is a natural human behaviour for us. And the moment somebody is given the diagnosis of dementia, we switch. Suddenly that person is wandering, suddenly that person is walking around with no intention. But actually I don't agree with that. I believe there is an intention, and I believe the bigger challenge is about us trying to identify that. We often, you know, in hospitals generally we talk about, oh, we've got a patient who's quite aggressive. You know, they're aggressive, they're hitting, they're kicking, they're really aggressive, it's because they've got dementia. And I'll always say, no, it's not. You need to change that terminology and think about it. When would you kick out? When would you hit somebody? Maybe if you're frustrated, you're really frustrated about something. So again, it's trying to step away from the fact that dementia gives an excuse for something and doesn't void us of responsibility, because the term challenging behaviour voids us of responsibility. It gives them the sense that actually all the problem is on that person, and it means we can't take responsibility for anything. Whereas if we change the terminology challenging behaviour for distress behaviour, what do we want to do when someone's in distress? We want to help them. We want to find how we can comfort them. We want to find how we can support them. So for me, the terminology is really, really important in changing the perceptions that we have. And that for me is half the battle. So, what about the media? Because the media influences everything, doesn't it? The media tells us how we should think about things. I admit that a lot of the pictures up here include headlines of the royal family. That just happens to be the case, not because I like the royal family or anything like that. But, you know, it's all about stressful lifestyle. Do this, do that, don't do the other, and you won't get dementia. It's where cancer was 20 years ago. Don't breathe and you won't get dementia. Don't go to sleep or you'll get dementia. It's all this scaremongering. It's all these really big, fearful media headlines. And actually, it does make us scared of it. It makes us scared of getting it, of supporting people who have it, of addressing the challenges that we need to, as a carer, as a ward, as a hospital, a trust, a borough, a city, a region, a country, and globally. Headlines like this make us very scared. And actually there was some research recently which was looking at the way that the media portray dementia, and it highlighted some really significant findings that actually most of the focus in any of the media to do with dementia was about the terminal stages of it. It was all very negative and it was all very terminal. That people with dementia themselves were very rarely the focus of the article. They were not necessarily included in the media coverage that was given out, so they rarely had the opportunity to speak for themselves. There was also an emphasis on the burden that it had on family. It was always perceived as a burden on the family. And that for me is really important because, yes, we need to be preventative. We need more research. We need to live healthier lifestyles. We need to improve our lifestyle choices so that we can try and reduce the prevalence. But for as long as dementia exists and is an ever-increasing medical concern and challenge, we need to readdress our perceptions of it. And we need to tailor our efforts to support good healthcare and to actually how to help people to live well with dementia while they're here. So yes, the media plays a big part in changing our perceptions, but we need to have a bit more positivity out there about good care and good practice. So globally, there are lots and lots of global perceptions, again, that people with dementia can't contribute to society, that they can't make decisions about anything, that they need help with activities of daily living, that they can't live on their own, they can't manage their own money, that they're vulnerable. Again, you know, it's all very negative, isn't it? It's as if the moment you get that dementia diagnosis, everything's stripped away. And actually, perceptions like these can be influenced by a lack of understanding, a lack of education, a lack of good practice stories out there, a lack of promoting the people who are getting it right and who are doing things right, leading by example. And I think actually there's a lot of joy in somebody who has dementia, in the same way that if they didn't have dementia, and that's what we need to start emphasising, because it's easy for us to get lost. So, as a wise woman once told me, we need to change our minds about people whose minds have changed. And this is another colleague of mine, dementia occupational therapist. And I think that's really, really important. That's a really important way to perceive it. And that's where national schemes like the Dementia Friends Initiative come in. And again, by the end of this, I'll tell you a little bit more about it. So, what about the challenges that we face? Because there's obviously a massive amount of challenges, and it was brushed on earlier in terms of the demographics of it, but there are about 850,000 people in the UK who live with dementia currently. There are 670,000 carers of people with dementia in the UK. The financial cost of dementia to the UK is £26 billion per year. Family and carers of people with dementia actually save the UK £11 billion a year. 25,000 people with dementia are from black and ethnic minority groups. 2/3 of people with dementia are women. 1 in 6 people over the age of 80 have dementia. 40,000 people younger than the age of 65 have dementia. And 2/3 of people with dementia live in the community, while 1/3 live in care homes. So it's a significant concern, isn't it? And it's an incredibly big impact within the UK. They reckon there'll be over 1 million people by 2025 and over 2 million people by 2051. So it's a significant challenge to the health economy. So what about globally? Well, globally, there's about 44.4 million people with dementia worldwide in 2013. 62% of them live in developing countries, and by 2050, that will be 71%. 7.7 million new cases of dementia are identified each year, implying that there is a new case of dementia somewhere in the world every 4 seconds, which means since I've been talking to you, that's quite a lot of people. Okay, so this number is likely to increase to 75.6 million in 2030 and 135.5 million in 2050. So to put it into perspective, if dementia care was a country, it would be the world's 18th largest economy, ranking between Turkey and Indonesia. If dementia care was a company, it would be the world's largest company by annual revenue, exceeding Walmart, which has got £414 billion a year, and ExxonMobil, which is $311 million a year. So pretty significant global issue. So for me, when we think about perceptions and we think about, the terminology that we use at a local level, actually when you put it in context of a broader level, it's really significant, isn't it? And as a wise man once said, it is far more important to know what person the disease has than what disease the person has. So Hippocrates himself said right at the beginning, it's much more important to keep the person at the focus of any disease process. And this is so important within dementia care. What makes that individual unique? We all have unique individual brains. We can do lots of scientific research about what causes dementia, about what cures dementia, but actually what makes our brain unique will always be individual and unique to us. So knowing what makes that person unique is the first thing we have to do in good dementia care. Do we know their personal history? So not their past medical history, not how the dementia has affected them, but their personal history, where their journey has taken them and how they've come where they are now. What are their strengths? We're very good at saying this person's got dementia and they can't do this anymore, they can't do that anymore. But how good are we at saying this person's got dementia and they're still able to do that and they were wonderful at doing this? So for everything we find a difficulty for them, we need to come up with a strength as well. What's normal for them? What are their normal sleeping patterns? What are their normal reactions to situations? Some people get cross about something and they say, oh, it's probably the dementia. Actually, it might just be the way that they normally would have reacted to something. Why does it have to be the dementia? So it's about knowing the individual and what's normal for them. Could we take a positive risk? We're very good at saying, no, this is too scary. We don't want to take that risk because it makes them too vulnerable. But actually sometimes taking a positive risk can be the most difficult one to take, but that can be the most successful. Is care being adapted to suit their individuality? So how flexible are we? We're very good at talking about person-centred care, but how much can we flex the system to actually meet in with their individuality? What is their health priority? We know what our health priorities are, and especially as working in a healthcare system, we know what we think people should be having in terms of medication, medical procedures, but actually what's the individual's health priority? So it's moving away from what's the matter and moving to what matters to you. And for people with dementia, they can very much do that as well. So the common approach to good dementia care is about remembering the uniqueness of the individual person. And the only way of doing that and judging whether we've got that right is by looking at quality of life. So some more research for you. There was a project that came out by the Alzheimer's Society called My Name is Not Dementia, which I think is a brilliant name for any piece of research that you can do. And it was carried out about the perceptions of quality of life as identified by people with dementia themselves. And they came up with 10 topics that were really significant for good quality of life. The first one was a relationship and somebody to talk to. The environment, physical health, sense of humour, independence, the ability to communicate, a sense of personal identity, the ability or opportunity to engage in activities, the ability to practice faith or religion, and the experience of stigma. So those were the things that came out as the top 10 that were really important for people with dementia in terms of quality of life. What they also found was that people with dementia, including people with severe dementia, were able to express their views about what was important to their quality of life. People with dementia have a clear need for everyday one-to-one social interaction that will have a significant benefit to their quality of life and their social inclusion. And they also found that there was quite a distinction that could be drawn between quality of life and health-related quality of life. So it didn't all have to be that somebody didn't have to be 100% healthy to say that they experienced quality of life. So their conclusion was that if the quality of life of those people living with dementia is to be defined by the person and their circumstances, then both public, private and not-for-profit sectors have to review our attitudes and policies to dementia. So we have to review the way that we are setting up the healthcare systems so that the person with dementia, who should be the main focus, is the one that's influencing the way that we do things. 30 years ago as a nation, we started to think about the fact that disability, what disability meant and how we could include people who were disabled to have access to everything. And now we need to start doing the same thing for people with dementia, because at the moment they're often missed out. So what about carers? Because carers play a massive part as well in the journey for people with dementia. And again, some more research from the Alzheimer's Society identified that carers faced a lot of challenges, and they play a massive part in the healthcare of people who have dementia. And as you can see, good person-centred care, obtaining a diagnosis, stimulating meaningful activity, maintaining nutritional requirements, decision-making in best interests. It's not always the same as what the patients maybe identified themselves as quality of life, but they're significant indicators, and they're something we really need to be considering. We were very lucky in our family. My grandfather was very assertive. He was very good at stating what Jannie wanted, what was in her best interests, and he made himself heard when he needed to. But not everybody's like that. Not everybody's got the confidence to do that. Not everybody knows how to do that. So these concerns from carers and from the patients should be really considered as a central part of any dementia service development. The other challenge that we have is actually what about in the healthcare setting? Because that's all easily said and done that we can include everyone's perceptions, but we know that healthcare and NHS trusts and hospital and community settings don't necessarily have that flexibility. So what are the challenges that the healthcare staff face? Well, there's always quite a few. I've just put a few up here. But people with dementia have very individual needs, and it's often in a very static system. So it can be quite difficult to put that flexibility in place. It's often reactionary care, not preventative care. And again, it's quite difficult to get there in advance of a crisis happening. There can be problems in releasing staff for training. It sounds simple, but when we've got a lot of stress on the healthcare system, releasing staff to training can be really difficult, which means that sometimes there can be lapses in whether staff have got the skills needed. Managing complex behaviours, moving away from the pharmacological approaches to managing difficult behaviours and actually trying more behavioural approaches and more supportive approaches can be difficult within a static healthcare system, within a ward environment. Best interest decisions can often be difficult. They can be based on our personal concerns and our concerns for the future and our ability to look at risk and not be able to weigh that up and not be able to come up with positive risks. It can be difficult to accurately describe the needs of people who have dementia. It can be a very unsupportive environment. It's very clinical, very plain. It can be a challenge to prevent a decrease in function because we know that people here are very unwell, and it's whether there's enough support in place to be able to support people to prevent any deterioration. Staff can be scared to do things differently, to think outside the box, to put a challenge in place to the static system. There can inevitably be compassion fatigue. If anybody's cared for somebody with dementia, it can be very, very demanding on your time, and that can be a real thing that people experience. And it can be hard to understand what's normal for people, because we get people who come in, we know very little about them apart from their past medical history when they come in. So as you can imagine, there are a hell of a lot of challenges that seem to go round and round and round, and we don't always succeed in dealing with them straight away. So what about the guidance? Because this is a problem nationally, this is a problem globally. Surely there's lots and lots of guidance out there. Well, there is. There's a hell of a lot of guidance out there. There's the Living Well with Dementia, the National Dementia Strategy. There's the Point of Care by the King's Fund. There's the Triangle of Care, which is to do with carer support by the Royal College of Nursing. There's delivering quality outcomes for people with dementia. There's improving quality of care for people with dementia. There's counting the cost by the Alzheimer's Society. There's the State of the Nation report. And that's but to name a few. And we're very lucky here because we have the Dementia Action Alliance that tries to pull all of those things together and give everybody who's trying to do and achieve the same things a bit of structure in coming up with action plans. But there is a lot of national guidance out there, and that's what we're trying to strive to do to achieve. So, what are we, as the Royal Free, doing to tackle the challenge? I'm going to have a sip of water before I start this next bit.
Are you giving our nurses adequate training?
Well, that was something that I'm going to come on to. I believe that might be one of the first things that we talk about. There you go, dementia training. So with the dementia training, we actually have, to date, 61% of our staff base trained in Tier 1, which is dementia awareness training. So that's pretty good to start off with. We offer dementia study days monthly. We also have bespoke training available to each of the wards at a more local level, and we have just designed a nursing assistant training which is called Making Specialing Special. So the staff who provide one-to-one support for people, more enhanced support for people with dementia, receive additional specialist training. And the Making Specialing Special training is identifying really that we've got some of the youngest professionals in the trust looking after some of the oldest people in the trust. So we go through things like what is normal aging? What happens when we get old? You know, what is normal before we look at something like dementia and the impact that that has? And we have a very high uptake of this. The study day and the Making Specialing Special day happen every month. They happen on all of the different 3 sites, and we do have a good uptake. The challenge can be about weighing up releasing people for a day's study or trying to facilitate an hour on the ward. But we're 61% staff trained at the moment, and that is ever increasing, which is really good. To help us to monitor that and our training and make sure that we keep providing the training, we have a national sequin for dementia, which is the government's way of saying we want to make sure that you are meeting the targets, that you've got dementia very much there at the forefront of your considerations. So FAIR is find, assess, investigate and refer. So we're finding people who are of the age group where it might be more prevalent. We are assessing whether there are any initial identifiers for it. We're investigating whether it's likely that it's not anything else. And if so, we're referring on for a formal diagnosis. So we consistently, as a trust, match the 90% that's required for that. And it's not just that we get to 90% and we don't try and get to 100%. 90% is our consistent achievement, and we will keep striving until we get 100%. Carers' feedback is another part of the national sequin, and I think I'll talk about that in a second. And then the training. So the training's there, we report on it nationally, as well as identifying that, as well as getting the numbers for the training, we need to get the quality in there as well. So in terms of the carer support, we offer carer support sessions, and they're every week. We have feedback questionnaires. We're looking into focus groups, having more regular focus groups to get some verbal feedback, increasing our links with the community carers groups, and we have a monthly dementia information stand. My personal details are also all over the hospital, and I'm contacted regularly by different carers. So there is still a bit of work that needs to be done, but we've got some things in place at the moment. And so if anybody as a carer thinks that you've got other ways that would be good to contribute to us, then please do get in touch. We're looking at having things like online surveys, so if it's easier for people to access a quick survey and a quick bit of feedback online, then we've got that available as well. We also brilliantly have within this trust a Reach Out for Dementia Volunteers programme. So I'm not sure how many last time I checked we had 40, but I believe it's significantly more than that. Volunteers who are trained to work with people who have dementia. They provide befriending support on the ward. They support people with the mealtime experience. They provide interaction and activity, and we also now have pets as therapy dogs who come onto the ward. So we identified that actually that social isolation, that lack of having anything to do day to day is really not good enough. So we're trying to address that issue by having volunteers available. We have lots of resources that we've been very lucky to get. So we've got My Life units, which are plasma screen reminiscence units, which have photos and videos and music from different genres, different areas, different regions, different parts of the country, which are used on the healthcare of the elderly wards. We also have a reminiscence newspaper called the Daily Sparkle, which talks about things that happened, 50 years, 40 years ago today. And it also has, my favourite bit is the bit with the missing lyrics at the end, because I get to sing with the patients then and try and guess what the lyrics are, which is always good fun. There's lots of books, there's audio tapes. We have something called the This Is Me document, which is designed by the Alzheimer's Society for us to be able to find out a bit more information about the individual person, and also the 8 important things about me, which is an easy reference guide for anybody who's working with a person who has dementia on the ward and can identify what they like to be called, what they maybe did for a job, what foods they like to eat and dislike to eat, and what activities they find interesting and interactive on the ward. So to make it an easier way for staff to be able to engage in that. We also, following on from the dementia project that I came into the trust for, the My Discharge project, we've expanded on that following its success. We have a new member of staff, so as well as an occupational therapist, we also have additional funding of a therapy assistant, and we've actually moved on to something called CAPER, which is a method of care that's been taken from all of the positive outcomes, really, and that stands for collateral. So we need to get a collateral history, a proper good collateral history from the person and from their care network. Assessment, we need to properly assess and make sure that we're assessing in a timely way, that we're working in partnership with the family, that we're enabling people while they're on the ward, and that we're considering risk positivity. So it's a method of practice that's taken from a good evidence base, which is also starting to infiltrate into our training as well, so that everybody is receiving that support. Yeah.
You're talking from the wards and then onwards. How much training is being set up to retrain GPs to be able to diagnose people from the beginning point?
That's something, if you're right, if we put that at the end and we can talk about that, because I know probably less about that than you do, but we can talk about that in a second. But that's a very good point, because it's all very well for us to do the training here, but we need to be linking in with the community services to make sure that there is that link there, absolutely. So the other thing we're doing is looking at environmental reviews. I think all the staff that work on the ward are all very well aware that this clinical environment isn't very conducive to positive dementia care. So Larch Ward at Barnet Hospital has just had a massive grant and is in the process of the design process of having a big refurb to be a dementia-friendly ward. We also have been granted some money for a cosmetic refurb here at the Royal Free site, starting off on the healthcare of the elderly wards, because if we can get it right there, we can get it right anywhere. To be able to address that and have more colour-themed bays, have much more interaction on the wards, make it much more friendly, a much nicer environment for people to be in, and also trying to look at things like the dementia-friendly signage, more dementia-friendly signage. We have some significant refurbishments going on within the hospital in A&E and outpatients, so we're playing a big role in that as well, in trying to make sure that those are dementia-friendly as well. We have a lot of support from our Royal Free Charity. They were the ones that originally funded the therapy assistant for the My Discharge project. They funded the reminiscence units, the dementia information boards that are out there for relatives, orientation boards and clocks on the wards, and also resources. So we're very lucky that we've got some money behind us that are enabling us to do that. When I first came into this post, I realised that I probably wasn't the only person who was trying to do my job. That there are lots of hospitals out there, and actually there must be other people trying to achieve the same things. So I set up a Dementia Lead Network for London, which we now have 32 members of, and we meet quarterly. And it is a way for us, different trusts across London, to actually be able to share some of our challenges, some of our successes, to identify positive funding streams, and to try and, as a trust and as London, and expanding out into the UK to try and centralise some of the achievements that we've had. I've been working with the National Skills Academy, who have been developing a dementia library, which has been really useful. I did a webinar for them recently. I'm also part of the Dementia Education and Training Network, which looks at the training that's on offer, available for all of the trusts. And I'm now recently become a member of the Clinical Strategic Leadership Group for Dementia Care in London. So by being part of those things, it means that actually as a trust, we're able to see what other people are doing, and I'm always one for sharing ideas. I don't think we should reinvent the wheel, and I'm quite happy to steal somebody else's successful idea if it works for us. So what we're working on still, because we're not there yet by any means, is looking at the sustainable training throughout the trust. We need to make sure that actually there is a very robust training in place, that it is to the right level that we need it to be, that the right people are getting the right type of training. We need to strengthen our links with carers, and we need to work much better in partnership with the carers. We need to develop our dementia strategy and review the policies that impact and influence people who have dementia in the trust, so that we can maintain high standards of care. We need to look at reducing the number of ward moves that happen for people who have dementia and try and streamline the process. We need to be looking better at advanced care planning and higher quality end-of-life care. Diagnosis and essential information and a flagging system, so when people come into hospital, it should be easy to identify that they've had that diagnosis and that we've got the key people identified in their care. We need to continually look at the environment, and I mentioned about the refurbs of A&E. We need to look at having a delirium and a dementia pathway, so that actually when somebody comes into hospital, they can expect a certain level of care. And we also need to improve the links with our community as well. So there are quite a lot of things that we're working on, and I'm sure there'll be some questions about that in a second. The last thing I want to do is to show you a bit of a video clip. And if you've seen this video clip before, then bear with me, but if you haven't, then I hope it works and I hope it's useful. Without even knowing it, you've just all become dementia friends. And we have some little booklets and some badges over there as well. So that's kind of the main bulk of what I wanted to talk to you about today, and I'm sure that you've got lots of questions for me. I guess the main thing is about the fact that, people with dementia do get by with a little help from their friends. The Dementia Friends Initiative is really significant when it talks about that, about it not just being about understanding, about it being a bit more than just thinking about the dementia, but thinking about the small things that you can do to help people who have the condition. That people with dementia, they want to be able to carry on with their daily lives, and they want to feel included in their local communities, but sometimes they do need a bit of a hand to do so. So it might be that you have to do something really simple, it might be making a significant suggestion for how healthcare can change, or it might just be noticing somebody who looks a bit confused in the community. But everybody in this room, everybody who enters this hospital, everybody who lives in the UK can play a really, really important part in supporting people to live well with dementia, so we can step away from these negative perceptions that there are of people with dementia and help them much better to live well with dementia. So that's from me, and so if there's any questions, then